It's Claudia Hoevener. She has been moderating yesterday. And Claudia is a researcher in public health. She actually joined RKI 2010, same time with me. And she is the head of the unit 28, which is on determinants on health. Her background is health science and nursing. And before she became a researcher in public health, she also worked in the field and on the ground as a registered nurse and as a field worker for health promotion and prevention for HIV and breast cancer in the US and in Germany. So in various hospital settings, so she really also knows the basic. She joined RKI first in Department 3, Infectious Diseases Epidemiology, where I now work. And then she turned to non-communicable diseases and Department 2, which is also on mental health. And her focus always remained health of migrants, participatory health project, underserved and undersurveyed populations, social determinants of health, health inequalities. So many things. Also her participatory research projects are linked to what we heard yesterday. And she will present the RKI perspective on health inequalities in Germany, a research perspective here from us. So please, the floor is yours.
Thank you, and welcome back. I'm very, very excited to speak today about the German perspective, or the I have to say the RKI perspective on health and equities in health. And obviously, I could probably talk for days about this, but I try to compile a short story consisting of these chapters, the chapters of one, the history of social epidemiology in Germany for people who are joining us from somewhere else, so you get an understanding of how that went. Then I will talk about some of the results of our department, social determinants of health, in terms of health inequalities. I will then talk also about data gaps. We heard about some of them already yesterday. Talia, I will come back to what you said. And then I will give some future perspectives, what's important for us in the future and where do we want to go. But okay, let's get started. A good story starts with once upon a time. And once upon a time in Germany, there were pioneers of public health and social epidemiology here. And those are Salomon Neumann and Rudolf Virchow, which were the first to look at medicine as a social science. They were both doctors, they were both politically engaged, combining that, which we know is important. And they were looking particularly at hygienic living conditions in Berlin, but also at the link between social inequalities and disease. And there are two quotes that I want to share with you that are very kind of famous. One is of Salomon Neumann, who said, medical science is in its innermost core and essence a social science. So I couldn't agree more. And medicine is a social science and politics is nothing more than medicine on a large scale. So I think if we look back at them, they were pretty wise words that we are still working with. And in this time, there were also some other researchers. This is researchers working already on showing health inequalities. And this is an example from Behlen. And Behlen is where I'm from, Bremen, about tuberculosis monitor and mortality. And we see in dark blue the poorer, and we see that the poorer in both age groups were more affected by TB at this time, which is probably not very surprising because it is also due to living conditions. We know that. So Then, after this promising start, there was a long gap in data. Definitely, of course, also due to the Nazi regime, and afterwards, after the Nazi regime, also due to the crimes that were committed in population health. So population health was something that was a taboo for a long period of time. And just in the 90s, we started, or I did not, but people started again looking at health inequalities. And these are two examples of papers which were on cardiovascular diseases and health inequalities in cardiovascular diseases, and also on theoretical frameworks and also the status quo of health inequalities in Germany that were released at that time. Both were more focusing on socioeconomic dimensions. But what about RKI? You see, this is the survey history at RKI, and we can say that ever since the BGS 98, we started slowly doing analysis on health inequalities, and also published them in health reporting. And I want to mention someone who was the trailblazer here and a pioneer in this, and that was Thomas Lampert, who passed away in 2020. But he really, if you look him up, there's so many publications on health inequalities and various outcomes, mortality, and also throughout the life course, different age groups. And he was awarded postmortem the Salomon Neumann medal. So basically, this is the circle closing. But where do we stand today? So this is our unit, and this is basically the RKI, the organigram of RKI. You see there are a lot of different departments, and you can't really see us very well. But we are in Department 2, as was already mentioned. And of course, we're not the only ones doing research on health inequalities. But the work I will be presenting will be focusing more on what we do. But we also work together in this with a lot of different units and departments, because health inequalities or social inequalities are a topic that is very important for all kinds of different outcomes in different departments as well. So the objectives of our unit are to monitor social determinants of health and the resulting health inequalities, taking into account relevant demographic developments, such as demographic change, for instance. We focus, for one, on socioeconomic dimensions, but also on migration, family, and work, and also sometimes on other social determinants that are important to us. And we also do analysis if we do not have an individual data, and also in general on regional socioeconomic differences. So basically also comparing regions and how they stand in terms of disparities. We report our results. That is one of the official tasks for policy advice. And one of the particular focuses is here to identify groups and regions with particular prevention needs. We use all kinds of different data sources, like a lot of you probably do, but the focus is on RKI health surveys, but also registry data, official statistics, and other data sources that we can use. Now I come to some examples and key results. Of course, this presentation cannot live with some graphs, but I tried to keep it to a minimum. So first, let's get started with something kind of overarching, which is socioeconomic inequalities in poor self-rated health in adults in Germany. And we see always in dark blue people with a lower socioeconomic position. And light blue is higher socioeconomic position. And we see here a social gradient in poor self-rated health in all age groups and in women and in men. But we also, when we look, this is not, self-rated health is very overarching, but if we look at particular diseases, we see differences in almost all conditions, chronic conditions. Here's some examples with coronary heart disease, diabetes, COPD, and depression. And again, we see in dark blue people with a lower socioeconomic position. And we see that for all these conditions, they are at a higher risk of reporting these diseases than people with a higher socioeconomic status. But a very important topic that also Michelle and also Terje, you mentioned yesterday, are children, the health of children. And we know that if there are health inequalities in early life, they will most likely manifest also in later life, throughout the life course. So it's really important, of course, to look at the health of children. And here we have 3 examples from our KICS survey. And we see first, before birth, maternal smoking during pregnancy. And here we see again that women with from a lower socioeconomic position group have higher prevalences in smoking during pregnancy. In terms of breastfeeding, we see that also women, so basically right after birth, we see that women with their lower socioeconomic position less often breastfeed. And when we look at later at adolescence or childhood mental health problems, we see that they are reported more often also by children from families with a lower socioeconomic position. So basically, we see what we saw yesterday also in Germany. I think that's something that we can summarize. Here is a trend. KICS enables us to show trends, and here we see basically over a time span of like 12 years the development of overweight. So we measured in 2003 to 2006, and then again up to 2017, and we see that the gap has become bigger in terms of like prevalence of overweight, not so in obesity. So, but we also, we heard yesterday by Terje about data gaps. Basically, he already mentioned that here, I mean, this is mortality by socioeconomic position, and we see Germany's not there. And Germany is not there because we do not have a registry that, you know, is linked to socioeconomic position. So we basically cannot report data on this. So we already yesterday identified this as a big data gap, and Terje, I will definitely call you to, maybe you can help us to convince you know, policymakers, or so we can change that. But of course, we do have data on life expectancy, and I want to share with you how we try to bridge this gap. So we have 2 approaches. One approach is data is basically sample-based estimations. So this is data from the German socioeconomic panel and life tables. And what we see here is, here we look at income as, you know, the indicator for socioeconomic differences. And we see on the top, the richest, and on the bottom, always the poorest for men and women. And we see that there is the difference between the top and the bottom group. In women is 4.5 years, and in men is almost 9 years. So we do see big differences in life expectancy, of course, based on estimations. And when we look at the trend, we do see, of course, in general, that the life expectancy is going up, but we also see that the gap is not closing, but it's widening slightly. So basically, about flattening, there's no flattening to be seen in these estimations. There's a second approach. The second approach is on area-based data linkage, so choosing an ecological design. And for this, we use the German index of socioeconomic deprivation that we in our unit built. So it's based on the 3 dimensions that go usually also into socioeconomic position: income, education, and employment. And we use, you see here some other examples that go into this index to be calculated. And on the right-hand side, you see Germany and the distribution. And so in very dark blue, you see the less wealthy or poorest regions, resource poorest regions, in terms of income, education, and employment. And so we see that's particularly in the north and northeast. So, but we can use this index also to look at life expectancy at birth by district level. So it's on district level, and socioeconomic deprivation. And what we see here is, first of all, also, again, that life expectancy is going up, but we see, again, in dark blue and light blue, and we see that women have a higher life expectancy. So we see a big gap, and that gap, again, remains the same or is increasing slightly. Now we can also use this example shows how we can tap information on cause-specific mortality and make use of for social epidemiology. So basically, if we look at the gap between the wealthiest and the poorest, I say it's a little simpler to simplify it, and if we want to see what explains, what causes in mortality explain this gap, this is basically the result. So we see that over time, in general, cardiovascular diseases and cancer are the most common causes of mortality that explain the gap. And in the lately, cancer has become more important in green, as you can see. So, but now, chapter 2. Let's talk about migration, diversity, and health. So Germany is a country with a long-standing history of migration. At this, right now, 24% have known, of the people living in Germany have known or parental migration of migration experience. We already heard yesterday how important it is to look at migration in a very differentiated way. There's a lot of heterogeneity in terms of one of the reasons why people are coming to Germany, how they come to Germany, how they live and are received in Germany, and what their chances are. So basically, we know that the effects of migration on health vary depending on experiences and perspectives before the migration process, during, and after. So I think one of you already gave an example yesterday, but I just want to repeat it to illustrate that if, for instance, I come to Germany as a as a worker and I have a work visa and I fly here, my migration process is pretty smooth. I enter a plane and I decide that I want to migrate. And then I get to Germany, but still, I don't know how I will receive. I might be able to work, but I don't know if I have community, if I have a social network, and so on. So, but if I have to leave the country I'm at because I'm forced to, and I have to go on a long travel journey, that is exhausting and that might entail a lot of very traumatic experiences. And I come to Germany and I don't know if I can stay because I don't have, a permit yet. And I get there and I live in a shared accommodation that is completely different. So I just explain that one more time so you get an understanding of how important it is to really report differentiated on migrant health. And we tried to do that with a project that is called EMIRA, that lasted six years, where we collected data, worked on concepts, and did quite a bit of stuff. If you're interested, look it up. I could talk again about this for a long time, but today I will just show one slide that shows some of the results. What we did in EMIRA, for one, was conduct of a survey in selected among selected nationalities, people with selected nationalities, common nationalities in Germany. And here we see the prevalence of depressive symptoms within the last 2 weeks. And what we see, you see there's a red line, and everything to the left are protective factors for depressive symptoms. And everything that is circled is significant. Everything on the right are risk factors. And so what we see here as risk factors are are basically two determinants. One is perceived as experienced discrimination. So people who have experienced discrimination in their life, in their everyday life, are more likely to report depressive symptoms, and also people who feel like they do not belong to the German society. They don't have a high sense of belonging. And that, Rajesh, I have to think of what you said yesterday. If I don't feel I belong, I will not, I will feel unhealthy. And I have my own way of living, and someone has to understand it in order to reach me with prevention and also to improve my health. So we see discrimination is an important determinant, and I'm showing you this because the project also showed how important it is to look at different dimensions: socioeconomic situation, housing, work situation, and so on. And we all did this, but I'm not going to show you. If we want to report, or if we really want to analyze quantitative data in a more holistic way. So this is another example again from KICS, the survey with children and adolescents. And it's again on poor self-rated health. And we see here that discrimination, overall perceived discrimination and also racist discrimination are associated with a higher risk of poor rated health. But if we look at the so-called migration background, that's not significant. So significant are other factors. Migration itself does not cause illness unless, during the migration process I get sick, but it does not necessarily cause illness. But the surroundings and the living situation that people get into and the experiences they make, that does. So we talked a little bit about how what we analyze, but also how do we communicate results. And this is something I want to share that was also part of that we also did in this project, but also with lots of different departments. And those were recommendations on discrimination sensitive and inclusive communication. And that entailed basically of two major sub-projects. One was the recommendations, and that's basically that's a brief paper that is accessible for everyone to ask myself, how do I write responsibly about different populations, and in general, what questions do I have to ask myself? So this is basically helps to self-reflect, which is really important if we want to write responsibly. The other is a glossary, and that glossary entails a lot of different terms on migration, and in particularly on migration and health. And we did this because there are a lot of insecurities on what language to use. And people want to use the right language, but if they are not necessarily in the, so much in the discussions around migration and health, they might not know. They want to use the right terminology, but they might not know. So this is helpful and shows alternatives to some of the expressions we might use. And then we also published it so it's accessible, unfortunately, just in German, but a glossary is also, translating a glossary is something that we realized, that needs another 2 years, maybe. And there are also some glossaries already existing in English language. So, but again, there are not just the projects I showed on migrant health and other vulnerable groups. Here are some examples of projects also in Department 3, Infectious Disease Epidemiology, focusing on different groups, for instance, here, homeless communities or drug users, and also migrants from sub-Saharan Africa. So now I come to a little bit more, since we are an institute that also works with infectious diseases. I want to now go away from the NCDs and focus on infectious diseases and here on social inequalities and the COVID-19 pandemic. So this is Madonna. When Madonna was twittering from her bathtub at the beginning of the pandemic that it's going to be the great equalizer. The great equalizer because in front of the virus, we are all alike. Well, we all know that that wasn't 100% correct. And at RKI, we had very quickly, we realized, or we were aware that that most likely is not true. So what we did is initially we looked at reports from previous pandemics, for instance, the flu pandemics, and saw what lessons were already learned and what did we see. And we saw a big social gradient, of course, that was reported. And so we got prepared and in 2020, in the spring, we prepared a review compiling all the and research that was already done on COVID-19 and social inequalities. At that time, of course, a lot of ecological designs, almost no individual data, but we saw, not surprisingly, that there was a social gradient and to be expected. So, and what happened in Germany? So we then started to monitor socioeconomic inequalities in COVID-19 in Germany using the official notifications that were provided by the Infectious Disease Epidemiology Department and used the German Index of Socioeconomic Deprivation. And so what we saw is here, right in the beginning of the pandemic, we saw that basically the incidence was higher in areas that were wealthier. And we know why that is, because, the COVID-19 was kind of brought in by travelers and people coming back from skiing. And, I did, the Ischgl and all these different places. But then it turned. And we see here in the second wave, again in dark blue, that we see higher incidences in regions that are resource poorer. And then we see this also later on in the fourth wave. And then with Omicron, it was difficult. The data situation changed and it was difficult to see. So I'm not showing that. But in terms of mortality, we see an even clearer picture. In the beginning, the COVID-related mortality was not that high, but when it increased, we always saw that in regions or districts with lower socioeconomic resources, the mortality was higher. So that's basically something we've seen. And we also then we conducted zero surveys at the Robert Koch Institute, where one of them being the Corona monitoring nationwide with 2 waves. And I'm showing you wave 1 with nasal swabs and blood samples, and wave 2 just with blood samples. And here you see in wave 2 the SARS-CoV-2 infection risk by level of education. And we see that people with the lower level of education have a higher risk of acquiring SARS-CoV-2 than people with higher levels of education. So basically, we see a clear social gradient in terms of COVID-19. We also, of course, did something else, not just do data analysis, but also, especially in the crisis management team, there were recommendations for health authorities that were released. For instance, for marginalized population groups, for homeless. And also we did a policy paper on social inequalities in COVID-19 that we released to the ministry, just to name a few of the initiatives we did to try to support also people who are working in the field and politics. And then again, children. I mean, COVID-19, we now looked at the direct effects of COVID-19 or of SARS-CoV-2 infections. But here we see the subjective mental health by income and type of family, but later. So basically, this data was collected between 2022 and 2023. And we see here, we also see a social gradient that the subjective mental health or poor subjective mental health is reported more often in families with a lower income, and also more often reported in single-parent families as opposed to two-parent families. So to summarize, we saw an improvement of the data situation over time. I've given you some of the examples we use in health monitoring, but there are still some gaps. For instance, obviously, mortality, we try to bridge the gap, and also in terms of migration, diversity, and health, there is still much to do. And also what Rajesh was really pointing at yesterday, to involving community more in our research, and definitely to really fully understand the life circumstances of different groups. And then we see a social gradient in infectious diseases, and this is something that we know and that we can use now to integrate also as lessons learned for future pandemics. And that yet has to be done. So what's next? So for we heard yesterday already that there is no health inequity monitoring right now formally established in Germany. I mean, we do a lot of analyses, but we do not have a regular reporting. But we are planning on changing that and establishing that, because our Department 2, is now working together, of course, with Department 3 on establishing a public health surveillance, focusing on NCDs and CDs and comprehensive public health surveillance with our own new database, which is the RKI panel, so a panel survey that will be conducted, over time, and in health information system where we disseminate the results in a way that it's really accessible to our target populations. So that is one next step, a big one, though, I have to say. And that next step will hopefully also enable us to disseminate, to develop more appropriate dissemination formats for different stakeholders. And I think we are pretty good at, catering to the scientific community. We are better now at policy papers, but where we really also, when we do research on underserved groups, it's extremely important to also give the results back to those underserved groups. And that is something where I feel we have a lot of potential, development potential. Then addressing data gaps, of course, that is something that we also hopefully will be able to do with the panel over time. Also integrating children's health, I've showed this, how important this is, and also integrate in different subgroups that are at a particular risk for NCDs and also CDs. And then there's also the topic of climate change. And of course, we have a group on climate change here at RKI, but also looking on health inequities and climate change, and starting to really looking at the indicators we can use to measure that now is also something that is really important and definitely has to be done. And then, of course, a lot of cooperation, collaboration, and what I've shown to you today, it's really, I mean, it's not my work. It's also, it's partially the work of our unit, but it's also the work of a lot of different people involved at RKI, but also from other partner organizations that we work with in different projects. So I want to thank basically everyone who contributed to this presentation. So, and I want to thank you for your patience and your attention early in the morning. And now I'm open questions. Thank you.
Many thanks. Okay. Many thanks, Claudia. I'm sure there will be questions. I saw someone raising their hand online as well already. So we have online participants, many. So we start right here, please.
Thank you. Katharina Wartner, Center for Planetary Health Policy. Thanks a lot for your talk. My question would be whether you are ready or are planning to apply an intersectional lens to your work and the analysis that you do. Thank you.
Well, we saw yesterday, I don't know if you were there yesterday, a great example of intersectional analysis. And we are definitely, I mean, that's something that's also on the list of new approaches that we want to implement. We have one project where we try to implement this right now, but I have to say, especially with quantitative data analysis. I mean, with qualitative data analysis, I think it's easier, and I would say we do have definitely some experience in doing that, but we are in the process of learning that, and we are really. Maybe I should do that. Terje did that yesterday so well. So we are also asking for support, and and if anyone is interested and is really because it's not so simple to apply intersectional approaches in quantitative data analysis. So it's something we are looking at and we want to implement, but we are not quite there yet.
Many thanks. So we have some questions in the chat. You prepare more, please, Turit.
Yes, so we have a question and it goes as follows. KIGS and DEGS, two cohort studies. I'm sorry, my chat just moved. Let me go back. KIGS and DEGS, two cohort studies together with GEDA are or were the core of monitoring instruments for health and health inequalities in Germany. What is the state and future of these two cohorts?
So we are in the process where I mentioned that we are establishing a panel, and it is definitely possible to implement the KIGS cohort into the panel, and we are right now exploring how we can do that. But in terms of like KIGS is for one cohort, but it was also, basically a study that was doing repetitively, and so we were able to, do trends. So that is something to be determined, and I can say that the question of children's and adolescents' health is something that is really important to us, and we are right now also talking with the ministry on how we can implement that properly into future monitoring.
Many thanks. Any more questions here in the room? Please, Thomas Caesar.
Thomas Caesar from the Unit of National Health Reporting. Thank you, Claudia, very much for this impressive talk. Looking from the health reporting perspective, we get a lot of positive feedback from the scientific community and from the public health community. But there's, a limited response at the level of political interventions or things like this. That's a touchy topic, I know. But and this question is not directly at you, a person, but maybe we could use this international experience we have here in the lecture hall. Is there any idea or any specific topic that has shown to trigger political response?
Thanks for that great question, Thomas. That would be great. Maybe someone has a good idea on that, because that's really, that's, as you said, this is something that we've been seeing for years and years and years, ongoing, continuing health inequalities and definitely inequities in terms of chances of people. Does anyone have a good idea on how? No. That makes me feel, I would have really liked it, of course, if you had a quick answer to this, but at the same time, I think it shows the problem. It shows that it's a complex topic, and it's a topic where it's something where we need intersectoral approaches, and it's not that easy to get politicians to listen or to, well, listen, yes,
I think
act.
Dr. Mugabe wanted to say something. Please.
No, thanks for. No, thanks for the question. I just wanted to say that I think the one area where we have actually seen, political movement has been in the HIV field, and how, in fact, political commitment has been able to galvanize the international community to act on a particular challenge around the concept of, international solidarity and shared responsibility. I think it has been one area where I think not only at an international level, but I think in sub-Saharan Africa, for instance, most of the initial, AIDS response have been led at the most, high political level. In fact, in some cases, to the detriment of the AIDS response. South Africa is a typical example where political interference actually almost scuppered the entire, national AIDS response. But we also know of countries where, in fact, if it were not because of the political commitment to act on what, essentially were countries facing almost extinction. If you look at the HIV rates in Botswana in the 90s, I mean, it was such a catastrophe that took the, a whole president of Botswana to go to the United Nations and say, I need help, otherwise my nation is facing extinction. So there are areas where, in fact, political commitment has actually helped to move the agenda forward. And I would like to argue that HIV is one of them. And I hope we can see more.
I hope so too. So there are more questions now coming up. First, Dagmar Stark, please. And then we also have a chat.
Thank you. Not really. Thank you. Not really a question. Thanks, Claudia, for your nice presentation. My name is Dagmar Stark. I'm director of the Academy of Public Health Services in Düsseldorf. And my hypothesis is that politicians always like to listen when there's a big catastrophe, like you said, the HIV catastrophe, the COVID-19 catastrophe. So every time when the risk of mortality is really, really high for the whole population, there's something moving. But NCDs are not that visible. I think, Thomas, it's a good idea to question why politicians or how politicians could listen to health reporting results. And I think it's a good idea to implement the RKI panel. But we have to raise awareness for NCDs. This is the main threat. There's always something like infectious diseases, of course, and some countries are more at risk than others, besides of pandemic situations. But I think politicians have to get aware of what is going on with NCDs.
Anything, Dagmar? And now we go to the chat again, Turit.
Thank you. We have a spoken commentary by Matthias Anderheiden. Matthias, if you can hear us, please unmute yourself and the audience should hear your comment.
Yeah. Can you hear me? Yeah.
Perfect.
Okay, thank you. Yeah, thank you, Claudia, for this interesting talk. I have a question, a general question about the role of the socioeconomic status, because we think usually socioeconomic status as a mixture of educational aspects and economic aspects and maybe also further aspects. But can you distinguish which roles are played by educational aspects and economic aspects in these health inequalities that you showed us? Mm-hmm. Is this general possible in the data? Or?
Yeah, that is definitely possible, and that's something that we actually I showed this because it's sometimes it's easier to grasp sometimes as a combined measure. But right now, when we are doing analysis, we usually use the dimensions separately to see what is really the driver, because sometimes it's more income and sometimes it is more level of education. Sometimes, as in with the German index of socioeconomic deprivation, it's good though to combine it as a measure, especially I think for policymakers, to get a more comprehensive perspective. But in general, we are right now using the singular indicators, education and income in particular, and we do see differences in terms of the different outcomes. But if you're interested, Matthias, we can also, I can show you some of the, or send you some of the publications where we've done that, so you see what triggers what. Okay?
Okay, thank you.
Okay, so another question in the chat, or written or verbal?
I will read it out.
Okay, thanks.
Another question for you from Aruna Bhattacharya from Bangalore. She's joining from Bangalore, India.
Wow.
And she's writing, I have a query which is from the context of what Claudia is discussing and also at the RKI broadly. I wish to know about possible collaborations with institutes based in India. I work with Indian Institute for Human Settlements in Bangalore, and I lead public health and urban health research and practice. We see health in intersection of social, cultural, economical discourses in the urban and the global south.
Well, thank you very much. And thank you also for that description. It sounds like we have a lot in common, and we should probably discuss this in the future in terms of collaborations. I don't know if I can speak for the whole RKI. I can just speak for maybe Mr. Schade, if you want to add on. But in general, we are definitely open. And I think it's very interesting to discuss issues like health inequalities and equities on a more global level. Also, that's something that, of course, the Department of TIC is doing. And we heard that yesterday, and I think Terje made that point very clearly, how important it is to not just look at the North, but, really a comprehensive global view of health inequalities, because we see them everywhere. So I think there's definitely openness for collaboration. So maybe you just want to contact us, and then we see how we can follow up.
Many thanks, Claudia. Any more questions in the chat? Yes, Turit, please.
There's a question regarding what you shared about women with low socioeconomic status and breastfeeding. And the question is if there was any studies that tried to also understand some of the reasons why women may choose to breastfeed less.
I think there are different explanatory models, and I'm not an expert on that. But, there are definitely, one of them is also midwives not necessarily providing that option to people from lower socioeconomic status groups in the hospital. So it's definitely, I think it is a combination of different things, but that is one that in the in care, different things are offered to different people, and also maybe assumed by different people. Another one could be it's the question of health literacy is very loaded, but it could be one of the issues that women might not know the potential benefits that result from breastfeeding. And then, of course, chronic stress is something that is also more prevalent in lower socioeconomic status groups, and stress is not very conducive to breastfeeding. So those are just 3 ideas, but it's definitely, I'm not on top of the literature, so just But maybe someone can add up on that.
We have another question or comment here in the room.
Hi, I'm Majdi Laktina from International Rescue Committee, Germany, and I work in the Participation, Client and Community Engagement Department. I have a question regarding first trust in public institutions. Do you have any ongoing project that monitor this factor, this aspect? And do you have any ideas how to decrease this gap? I would say, according to my experience, there is a gap in the trust in public institution, and I think Robert Koch Institute is considered one of them. My second question is regarding the open invitation you have said about collaboration or support. It is for individuals, it is for institutions, and how do you, is there a place where we can check what kind of support if needed and how much support we can offer? Because that would be really interesting for me personally.
Yeah.
Thank you.
Thank you. So in terms of the RKI being an governmental institution, and the lack of trust of also participants of research, that is something that is definitely the case, and we are aware of that. I can also, again, just speak for my unit. I can't speak for the whole RKI because, I mean, we do have a team, on social media. We do have a team on press and media in general. But when it comes to, I can just give maybe an example from the GEDA Focus survey. When it comes to wanting to have people participate in surveys, the best way to do that is to talk with them. I mean, it's so basic. And what we saw in GEDA Focus was that people who were considered hard to be reached, if interviewers knocked at their door and explained to them again what this was all about, why this is important, and so on, and why it's a good idea to participate, people were more likely to participate. So basically, we need dialogue. That's what that is. Then, of course, there is, especially when we work with populations that are particularly marginalized, or also that might live in very difficult and with difficult resource situations. So communication, I think, is the key. In order to build trust, there's no other way. And I think that's definitely something. I can say that we have done that in some of our projects, but not in all of them. And that's what I meant. That's definitely something for the future. Also thinking about community boards, for bigger surveys, something like that. Your second question, I don't think I have right now a good idea on how we can do that, but I mean, you can definitely come. We know each other, but you can come up to me, and maybe you can just shoot us an email, or we just talk afterwards, because what I mean is it's really important for us to increase collaboration, but also support, and if for skill sharing and also experience sharing. So let's see how we can do that, and how we can do that concretely. I'm sure we will find something.
We can also use the coffee break. Now there are coming questions popping up. So maybe we have two more, and then we go to the next speaker. He's up there. Yeah.
Thank you so much for the presentation. It's Harsh from RKI as well. I'm just still reflecting on what was mentioned on mobilizing politicians. And I feel like this is a point that was raised yesterday. We still think, okay, how recommendations are really bringing action after that or not. And it just occurred to me whether in parallel with these analysis, there is a sort of an economic analysis on the cost that actually health equality costs. And it's unfortunate to have it see it in this mindset that we enforced trying to think from that point of view, but maybe this is something that drives action on a political level to really make a change. So it's just a reflection, an open question, if such economic analysis is being done in parallel with this. Thank you.
Thank you so much for that. I think that's a very valid point. That's where it hurts, right, when it comes to costs, or when we show avoidable costs if we change things, or through different interventions. I think that we are right at this, we know that it's important, and we've seen that in the HIV pandemic or epidemic as well. That's definitely that cost has sometimes really helped the argument of cost. So that's something that we have to look into, something probably that's easy to do is, and I talked with Thomas about this yesterday, is looking at the workforce and looking on what prevents people to stay in the workforce and drop out early, because it's probably easy. So that's something that we could probably look at. But yeah, I think that's a very, very good point. We'll definitely take that with us. And if you want to discuss it some more, let us know. Thank you.
Okay, so the last question.
Yeah, thanks. So you mentioned before that you're going to look more into the nexus of climate change, health, and equity. I was wondering whether you could say a little more on that, like what the approaches and questions will be. And actually, I think it links nicely to what the previous participant asked, because in terms of costs, I think there is lots to show, actually, avoidable costs in that area as well.
Definitely. So in terms of climate change, we are right now, we are basically right now have a working group that is working on climate change here at RKI. And so we work with them, and we are just, there's going to be a review being conducted, first now compiling the evidence on health inequalities and vulnerable groups in terms of like climate change that's available right now. And then, of course, there's also, this group is also looking at different indicators for climate change to be measured, and is also taking into account social determinants of health. So that is in the works. But then also, I think it's very also in our unit. We have established a small working group where we really want to see how we can push this topic and how, with the resources we have, and that most likely will eventually be a project or something where we then establish, how we can integrate that better into, into health inequalities in general, because the resources, are always limited, unfortunately. But so those are the different ways that we're working on it. But there is a lot of room for more, and we are aware of that. Yeah. Mm-hmm.
So many thanks, Claudia, for presenting our work so nicely and answering all the questions. The discussion is still ongoing, as we see. There are some questions in the chat now unanswered. Maybe you can take care of them later,
sure.
Because I would like then to introduce the next one. Many thanks, Claudia.
The stage. Thank you.